Dr. Sharmila, who's here today to talk to us about rethinking the management of major burns. She is a university distinguished professor and chair at the Texas Tech University Health Sciences Center in Lubbock, Texas. She's clinically active in trauma, burn, and acute care surgeon who has won over 50 awards for clinical, academic, and research excellence and service during her career. Dr. Sharmila has published over 100 peer-reviewed scientific articles in addition to numerous book chapters, peer-reviewed presentations, and national and international invited lectureships. She also holds multiple national leadership and quality assurance roles and is committed to surgical education and, in particular, safeguarding the quality of general surgery residency training, and serves on the ACGME Residency Review Committee for Surgery. Let us welcome Dr. Sharmila.
A smaller area of the site. And so those are two very new techniques that we are using, and that's kind of what it looks like when they're in. And you can see this is a later picture. You can see the vessels starting to ingrow through that BTM. So all of this is something we've really started using in the last few years, and it's really improving results for our patients. I also want to talk a little bit about a child. We do pediatric burns as well, the center that I'm at. And this was also quite a significant flame burn in this young child. You can see the burns look different. They're not quite as deep. In this little girl, they're light pink versus that deep red and white and leathery that was in the gentleman you saw a little bit ago. Even on her arms and legs, significantly less. This little girl actually did quite well and didn't end up needing skin grafting. We did enzymatic debridement, and we actually did it twice a day on her. We almost never do that. But being a child, it was possible and easier to do and feasible. We were able to get away without having to do any skin grafts on her. Even though some of those areas, as you can see, especially on that arm, were a little bit deep. The pediatric resuscitation, we are using a very similar protocol. We have a higher goal of urine output. For adults, we like to have 0.5 mils per kg per hour. For children, we like to have 1 mil per kg per hour, especially if they're below the age of about 7 or 8 years old. We definitely want that higher goal. And you do need to know what normal heart rate and blood pressure are on these children, because we are not a pediatric unit, even though we treat children. You know, it's not an everyday thing for us. I have a chart that has normal heart rate and blood pressure ranges for all these age groups, and we stick it to the door so that the nurses and physicians and everyone has an immediate way to refer to that and know what normal is for those children. And this is very similar. So this is the fluid resuscitation protocol. It's a little longer, and you'll notice the difference is we are giving some maintenance fluid with D5, because if you remember, children need glucose reserves. And so we add the D5 half normal saline in addition to the lactated ringers that we're using for resuscitation for children, which we do not have to do for adults. And then when you get to the stage 2 resuscitation, it's very much along the same lines that you saw, with the dosages adjusted based on the age of the child a little bit, with 7 years being the cutoff. And this is the table I was talking about, where we stick it to the door of each room with the child, just to remind everyone what the normal ranges for these vital signs are. I think it's a very simple thing to do, but I definitely encourage it if you're taking care of children who are injured and you're not a pediatric specialist. So this is what I was mentioning as some of the new things we're using. This is sort of the back to the future part of it. And so 3 of the things that we chose that I wanted to highlight that are relatively new and really game changers. There's lots of new things, but these are the big ones. The BTM is the bottom left. You can see it's basically a synthetic matrix that is applied to the excised wound bed. The RECELL is in the bottom right, which is the product that helps us create this spray-on skin, is what it's advertised as. It's essentially the patient's own skin that's hydrolyzed and the cells taken out and then sprayed back on. It can cover a much wider area than a skin graft. And in the middle is the new harvesting device we use, the amalgatome, which is really does seem to be a technical improvement over the dermatomes we've been using. Otherwise, it gives a very nice, smooth harvest. And interestingly, we can also set it to a depth and use it to excise the burn as well. And so we've been using all 3 of these devices in combination and really able to get better results with that. I'm not going to go into a whole a lot about how these various things work, but it definitely, the amalgatome, we find that because it's a circular spinning blade, we have less mishaps, which less skipping. Sometimes when you're using a dermatome in skin harvest, it can get uneven. This tends to be a smoother use. The BTM stands for biodegradable temporizing matrix. It's a bit of a mouthful. And what's really amazing about it, unlike previous dermal substitutes and matrices that used to be popular, is that it is quite resistant to infection because it's just inert. It's not biologic. That's really quite unusual. Most things that have come up as dermal substitutes were biologics. First, we had xenograft, pig skin. We had allograft. We had cadaveric skin. We had things like Integra that were bioengineered, but still biologic. This is really the first synthetic matrix that got widespread use. And really, it is a game changer for us, at least. We take it down on about day 3 to 5, but it's about 3 weeks until we do the regraft over it. And then some fairly basic cleaning that is doable with trained nurses who are trained to look after it. And then resell is the final step, where it takes about 20 minutes to set up your skin ready to spray. It definitely heals quicker, and it does seem to give us a better cosmetic result. And there's actually quite a lot of literature now published showing these benefits of it. With combination of techniques, we've shown that we can reduce operating time, reduce operating number of days, and really have some better functional outcomes when they're ready for discharge. We don't have enough patients yet to really statistically present a lot of data on this, but a lot of centers across the US are using various of these techniques, and we're finding that this particular combination is really helping us improve our outcomes. Just some more images of patients who, sorry, just move that there. One thing I did want to mention, and I'm kind of sorry, I have to move my screen out a little. There are long-term consequences. The pictures on the right, you're seeing a skin graft that's healed quite well, but it's starting to have keloid and some hypertrophic scarring. And I bring this up just to say we're never one and done. This was a young person who was burnt a while ago and is clearly coming back to us with problems. These patients from major burns need to be seen on a pretty regular basis. And I'm going to go through a little bit quicker with those pictures. And I would be happy to answer questions and to hear from the reactor.
I'd like to welcome our reactor, Dr. Sushma Sagar. So today our reactor would be Dr. Sushma Sagar, who is currently professor and faculty in charge, Division of Trauma Surgery and Critical Care at the JPN Apex Trauma Center at All India Institute of Medical Sciences in New Delhi, India. She's course director and course faculty for ATLS India program and a faculty for National Institute of Disaster Management. Being a founder and executive member and joint secretary of the Indian Society for Trauma and Acute Care.
For a very wonderful talk given by Dr. Sharmila, and she has very comprehensively described the newer management and advancement in the management of burn injuries. And the pictures which you had shown, they were very expressive, and I think most of the people who are present here must have gained a lot from these expressive pictures and the content which you have shown to them. The take-home message I would like to emphasize here again is that we should remember our priorities and airway, breathing and circulation, especially for the burn patient. The B part involves the eschorotomy and the C part involves the avoidance of compartment syndrome. The resuscitation she has covered so very well, and here in our part of the country we also use the same Parkland formula. Very important slide which you had shown about the ORS, I think is a very key feature of your talk, because the places where the intravenous fluid line is not available or in the resource limited countries, I think the ORS can give benefit to the initial resuscitation of such patients. For the pediatric resuscitation, yes, the mention of glucose as a maintenance fluid, we all must remember. And the key indicator, urine output, remains the same for everyone around the globe. We should not be dependent upon other fancy gadgets for seeing the adequate resuscitation in such patients. Dressing, we all know, is a biggest armamentarium for any burn and wound surgeon. And you have brought in the fact that the usage of BTM and pre-cell has definitely changed the overall outcome of these patients, and definitely would bring down the after effects and the complications which we see after the burn injury patients as a long-term deformities. Amalgamatome, we have not yet seen in our part of the country, but the pictures and the videos which we have recently seen, it definitely is very easy to use. And the best part is that the debridement part and the taking up of the graft would become much easier, even for the people who are not trained in the plastic surgery techniques. And I must say that these days the trauma surgeons are also doing a lot of wound care management, and large wound debridement is required, and amalgamatome can become a handy instrument for all of them also. Now, a word about our part of the country in Asia and in especially in India. Burn is a major cause of concern, and a recent paper which was published in Lancet in 2019 describes about 20,000 deaths due to burn in 2019, so which is a very huge number. And the worst part is that it is the women, like in trauma, the more of male population gets affected, where in burns in our part of the country, the women are affected 3 times more than the male population. And the major cause being the domestic violence, homicide, suicide, and the dowry burning because of this. And that's why our government has launched a very robust program for the National Program for Prevention and Management of Burn Injuries. And I think in longer coming years, this might bring much change because the program has to reach to the rural areas also. Regarding our experience about the coverage of larger defects, we have recently tried to use and revive the usage of amniotic membrane. And because our colleagues were using that amniotic membrane for corneal grafting, so the expanded sheets we are using for the early coverage of these wounds. And I think people world over can revive the use of processed amniotic membrane. And second thing is the concept of cadaveric skin harvesting. So like we in Orbo, we do various organs are harvested. So similarly, cadaveric skin can be harvested, and that stored skin can come as a very handy, especially in the low middle income countries and the developing countries, wherein the use of or the availability of materials like BTM and Integra becomes very costly and not very easily available. So thank you very much, Dr. Sharmila, for a very wonderful talk, and thank you, ACT, for inviting me here. Thank you very much.
Thank you, Dr. Sushma. That was very enlightening for me as well. I appreciate you sharing.